What is Boutonniere's deformity? Do you ever get a forceful blow to the middle joint of your flexed finger? These all questions will be answered in this video, so stay tuned with us. Welcome to Physiogain community, and here we are going to answer your queries and will help you to enhance your physique. So our today's topic is Boutonniere's deformity. It can be defined as the situation in which an individual gets a forceful blow to his flexed finger and ultimately leads to the injury to the tendon that helps to straighten the middle joint of the finger. In this case, there are severe central strip tendon, and you can also notice the flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint. You may find a shortening of the oblique retinacular ligament. Boutonniere's deformity classification. First is mild extension lag, passively correctable. Second is moderate extension lag, passively correctable. Third is mild flexion contracture, and fourth is advanced flexion contracture. What are the signs and symptoms of Boutonniere's deformity? There is a pain on grasping or tenderness. There is inflammation around the joint. This deformity leads to the flexion of PIP joint and extension of the DIP joint. You can also see redness of the joint. A patient cannot fully extend his finger, which can also be considered as extension lag. What are the possible contributing causes? A person may have a forceful blow to the flexed finger. Rheumatoid arthritis can also be the possible cause. Central slip tendon injury. Osteoarthritis is a known cause of many problems. And lastly, infection. Differential diagnosis. It may be a fracture, you may be suffering from gout, mallet finger, and it may be a PIP joint flexion contracture. So now let's jump on to our main topic, which is physical therapy intervention for Boutonniere's deformity. You need to take rest to reduce inflammation. Splinting the finger with the proximal interphalangeal joint held in extension. When we are addressing pain, we need to apply ice to that region. So let's talk about the process through which we can address pain. First, we need to apply ice, then massage, then joint mobilization, then electric stimulation, and lastly infrared. If there is weakness and joint instability, we need to strengthen the extensors. This deformity causes a lack of flexibility, which can be cured by stretching techniques like intrinsic flexor stretching and fluid therapy. We can perform joint mobilization of DIP joint, soft tissue mobilization. Now let's talk about conservative management of Boutonniere's deformity. If the injury is acute, less than 3 weeks from the incident, then from week 0 to 6, edema control is initiated as necessary for digit utilizing Coban or finger stocks. A volar gutter is fitted, positioning the PIP joint in full extension with the DIP joint left knee for ROM. The splint is worn continuously. A dorsal splint may be fabricated in conjunction with the volar splint to maximize the full PIP joint extension. In addition, as the acute edema has subsided, a slender cast may be considered to maximize excellent stability and positioning of the PIP joint in neutral. Active and passive ROM exercises are initiated to all joints of the hand with the exception of the PIP joint that has been immobilized. The key exercise is both active and passive flexion to the DIP joint. This will place the oblique retinacular ligament on stretch and prevent the lateral band adherence and subluxation. Then jumping on to the week 6, active ROM exercises are initiated to the PIP joint of the involved digit 6 times a day for 5 to 10 minute session. PIP joint extension splint is continued between exercise sessions and at night. Week 7. Passive ROM exercises are initiated to the PIP joint as necessary. It is important to monitor for an extensor lag. Should a PIP joint extensor lag greater than 10 degree develop, the passive flexion should be avoided. The wearing schedule with the PIP extension splint can gradually be decreased. To decrease the wearing time, 1 hour each day should result in discontinuing the splint during the day between weeks 8 and 9. Week 8 to 9. Assuming excellent extension has been maintained, increased focus can be placed on maximizing full IP joint flexion with dynamic splinting or taping as necessary. The extension splint is discontinued both during the day and at night. The balanced exercises and splinting program is essential to obtain the optimal outcome. The initial splinting must ensure excellent extension at the PIP joint. The splint must maintain 0 degree of extension. Once ROM exercises are initiated, gradually increase the exercise session in order to minimize an extensor lag. It is extremely difficult to recapture extension. Exercises to emphasize include passive DIP joint flexion, extension with the PIP joint at 0 degree and blocking the MP joint in flexion while attempting IP extension. This is a conservative management of Boutonniere's deformity. Thank you for watching the video. Stay tuned with us.